All right. Well, thanks everybody for joining us. I'm Margaret Crone, and I'm the director of the Physicians Health Program here in Maryland. I am very, very happy to be able to present the next lecture in our Lemons to Lemonade series. This, I think, is going to be a very, very interesting lecture, and can't wait for all of you to hear it, and I can't wait to hear it as well. We also want to let everybody know that on October the 18th, we will have a symposium, the Physician Health Symposium. We'll have 2 speakers and a panel discussion. Very excited about that. So look for notices and registration information about that coming to you in the next week or so. And we're very happy to have it. I would like to also ask folks, if you have questions, please either put them in the chat or wait until the end of the presentation, and then we'll ask folks to raise their hands and ask the questions. What I'd like to do now is turn it over to Dr. Stephen Rockower. I want to also acknowledge and let everybody know how fortunate, how blessed we are to have Dr. Rockower here with us this evening. He has had one rough summer, and thank goodness you're here. So handing it over to you to introduce our speaker tonight.
Well, thank you very much. I'm happy to be here. You know, my body is not good, but my head is. So I'm working on it. So I want to thank everybody for coming. And I want to tell you something about Dr. Merlo. She's a fascinating person. Here's her bio. Dr. Lisa Merlo is a licensed clinical psychologist and professor of psychiatry at the University of Florida College of Medicine. Dr. Merlo earned her BA from Transylvania University, that's in Kentucky, and then completed her MA and PhD in clinical psychology at Wayne State University. She completed her postdoctoral training in clinical child psychology at the University of Florida, then earned a second master's degree in psychiatric epidemiology from the Washington University in St. Louis, while completing more postdoctorate training in substance use disorder epidemiology and prevention. Dr. Merlo's research focuses primarily on physicians and other healthcare professionals with potentially impairing conditions and clinician well-being. She currently serves as the Director of Research for Professional Resource Network Incorporated, which is Florida's Impaired Practitioner Monitoring Program, and the Director of Wellness Programs for the University of Florida College of Medicine. We are so pleased to have Dr. Merlo here talking to us and giving us her insights. Dr. Merlo.
Thank you for that wonderful introduction. I'm just going to pull up my slides here. Okay. Let me know if you can't see the slides. I think you should be able to now. So today I'm going to be talking about the role of PHP monitoring in restoring clinicians with unprofessional behavior to practice. And I recognized a few of the names in the audience. So I know some of you are familiar with PHPs. Some of you may be familiar with physicians and other healthcare professionals with unprofessional behavior. So hopefully we'll have a good conversation together today and be able to learn some things. So I don't have any disclosures. I am the Director of Research for PRN, which is Florida's Professional Health Monitoring Program, but no relevant financial relationships. 2 primary objectives for today is first, really explaining when PHP monitoring might be appropriate for clinicians with unprofessional behavior. And then importantly, what are the steps then that we can take to actually refer a clinician for PHP services when that might be warranted? So I just want to start with really the bottom line right up front. Unprofessional behavior is a controversial and complex problem. This is something that has really significant impact throughout the healthcare system. So we know that it impacts the clinicians and their colleagues. It also negatively impacts patient safety. And there's a lot of data demonstrating this, some of which we'll get into later. And that's really brought it more to the forefront of conversation and brought more attention to the issue because of the stress and the strain that it puts on the system, as well as the risk that it poses for our patients. Unfortunately, a lot of times unprofessional behavior is unreported or underreported, and often it's ignored even when it is reported. And so really, as a healthcare system, we need to do a much better job of addressing these issues. We do know, though, that in certain situations, professional health monitoring programs, PHPs, can actually be a helpful adjunct in returning clinicians to practice safely under specific circumstances and when it makes sense. And we'll talk about those circumstances. So I'm going to focus on two primary types of problematic behavior today. The first is what's called disruptive behavior. So that's any kind of, well, I'll get into the definitions in a moment. I'll also get into unprofessional sexual behavior and professional sexual misconduct. So I'll start with disruptive physician behavior. What even is this? And the problem here is there's really no accepted standard definition. We don't have a good policy or description that we can refer to know that's disruptive, that's not. It's kind of goes back to that colloquial saying of I know it when I see it. But even there's some variability, and what one person sees as disruptive, another may not. Typically, when we're thinking about disruptive behavior, we're thinking about any sort of behavior that creates a hostile work environment and negatively impacts patient safety. And as we'll talk about momentarily, this falls on a pretty wide continuum of behaviors. Typically, healthcare professionals are not presenting themselves for treatment or to PHP saying, hey, I have disruptive behavior, can you help me? Instead, typically it comes to the attention of the hospital system or the practice or the health, the physician health program or the Department of Health, the licensing board, because it's reported by the victims or individuals who have to work with them. So patients or coworkers are the ones most commonly bringing this to attention, if it's brought at all. The Joint Commission does have their own definition. This is probably the most widely accepted or utilized definition out there. They refer to as any verbal or nonverbal conduct that harms or intimidates others to the extent that quality of care or patient safety could be compromised. And it's important here that they say could be compromised. It doesn't necessarily mean that patient harm has occurred or that quality of care has been impacted, but that the behavior creates a situation in which that could result. It's considered any abusive conduct, including sexual or other forms of harassment, and just basically any behavior or behaviors that undermine a culture of safety. So here's where we can look a little bit at the spectrum of what sorts of behaviors might constitute disruptive behavior. And most commonly, when people think of a disruptive physician, you know, the stereotype, they're thinking of this left column, the aggressive behavior. So, you know, yelling at people, using a lot of profane language, throwing scalpels at nurses in the OR, you know, the bullying, the demeaning, even things like physical aggression. So, you know, pushing people, throwing things, as I said, hitting people, but also sexual harassment, as noted earlier, and even things like racial and ethnic jokes or sexist comments or other aggressive verbally or physically aggressive behavior that's, again, creating an unsafe work environment. And this might be physically unsafe or psychologically unsafe. Less commonly reported, but perhaps more often experienced, are the middle column, the passive aggressive behaviors. This is the individual who's making nasty, derogatory comments, you know, sort of saying things under their breath or behind people's back. The person who refuses to do certain tasks, you know, I'm not going to finish my charts on time. I'm not going to show up to this, you know, required committee meeting. I'm not going to show up on time for, you know, the lectures, whatever it might be. use of sarcasm, particularly when it's excessive or not in a way that they're, bantering with a friend, but something that's used in a more professional setting. Inappropriate notes. So this might be the person is charting and they're making comments about other clinicians and their plan of care, or things like that, that they're actually putting in the record their views that the other individual is not living up to their expectations. But again, not in a way as to promote better patient care, but more so in a way to embarrass that person or shame them. Veiled or implied threats, backhanded compliments. So my favorite example here is an individual I know of who used to tell people, "You're a really good trier." Excessive questioning. So not asking questions that are useful and helpful, but just really micromanaging and coming behind people and questioning every decision that they're making in a way to make them feel uncomfortable or lose confidence in their own clinical practice. And then the third column, the passive behaviors. So again, just showing up late all the time, losing their pager, or having their cell phone battery die, or forgetting it at home, so they're not responding to calls, not showing up when they're supposed to be on call on the weekend, causing a work slowdown because everyone's waiting on them. They're off having lunch while everyone's trying to get the case started, or whatever it may be. Giving a cold shoulder. So just ignoring people who are trying to interact with them in the professional environment, acting like they don't exist or they're not worth your time. Incomplete charting. So not putting enough information into the medical record to ensure that the patient care can proceed as needed. Avoidant behavior. So finding out ways to get out of things or to not put themselves in certain situations. Ignoring emails, the people who just, I don't check my email and act like that's an acceptable stance to take in the professional setting. So given the wide span and, the many different settings in which these things can occur, how can we really determine whether a behavior or a set of behaviors is disruptive or not? And so it's important to think about the what is it not column as well. And so here, if someone is providing criticism, but it's constructive criticism, and the goal is really improving patient care or improving clinician knowledge, saying, hey, I noticed when you were doing this, you did it this way. This is another way you might consider that I found works more effectively or more efficiently, or, hey, I just read this paper. Here's a new approach. What do you make of that? And, providing feedback in a way that is constructive and moving towards a better environment. Expressions of concern about patient safety. So if an individual speaks up because they're concerned that another clinician is putting patients at risk, and they're doing this through the appropriate channels, they're going to them directly. And if that doesn't get the desired outcome, then going to the immediate supervisor, that they're not jumping 5 levels up and going immediately to the CEO or immediately to the dean or something like that, but instead they're trying to resolve the situation within the appropriate chain of command. Then of course we want that to happen. We want people to speak up when there is legitimate concern. So that would not be considered disruptive either. Expressions of dissatisfaction with policies that are made, again, through the appropriate channels. So if a new person comes in and takes over the hospital and they start implementing these changes, again, that are putting patient safety at risk, or they're significantly negatively impacting clinician well-being, or there's other legitimate concerns, of course you can speak up about that, but again, doing it through the appropriate channels, doing it respectfully, professionally, not posting things on the social media, not taking out a billboard about what a jerk the new person is, but doing it in an appropriate way to try and get some resolution. Also, it's important to keep in mind that clinicians are human beings and all of us can have a bad day. You know, things can be happening in our lives that cause a single episode or kind of an out of character reaction. If someone just lost someone very close to them, they're going through a divorce, they're, you know, in the midst of a health concern, you know, something, and they snap at someone one time, and, you know, they've never done this for 20 years. And one day they, you know, it's just kind of the straw that breaks the camel's back, and they have an out of character reaction, then typically that wouldn't be the impetus for, you know, labeling someone as a disruptive person and, you know, taking all the steps. But instead, what we want to do is reach out to them with concern and figure out what is happening that's distressing them and causing this sort of a reaction. And then also a lack of perfectionism is not disruptive behavior. So, you know, healthcare professionals tend to be higher on scales of perfectionism or obsessive compulsive personality. And, you know, that typically serves us well throughout our training, and even to a large extent in our provision of healthcare, where we want to do the best job possible. But if someone else is not meeting your unrealistic standards, that does not mean that they are disruptive. It may mean that they are operating still within, you know, the clinical practice guidelines, but, you know, not specifically doing it exactly the way you would do it. And that's okay. That's not something that we need to be concerned about. So how problematic is this? Well, there's some older data suggesting that virtually all clinicians have experienced disruptive behavior at work, about 97%, in fact, about 77% witnessing disruptive behavior by physicians, 65% by nurses. Importantly, 40% of those individuals report that they were actually intimidated into silence regarding some questionable medical practice by a physician displaying disruptive behavior. So that means that they're seeing something that they think is putting patient safety at risk or otherwise outside the norms of clinical practice. And they're too frightened to speak up because they don't want to be targeted by the physician. They don't want to be bullied. They don't want to have retaliatory actions taken against them. And so you can see that creates a very unsafe environment for clinical practice and for the patients who are being treated. The thing though, is that even though almost everyone has experienced disruptive behavior at work, it's a very small percentage of clinicians who are actually displaying the disruptive behavior. So the estimate is about 3 to 5% of physicians are displaying disruptive behavior. And so they're impacting everyone else around them. It really spreads quickly and far, the impact of this type of behavior. A more recent study looking specifically at operating room workers, so anesthesiologists, surgeons, nurses, CRNAs, etc., they reported experiencing or witnessing disruptive behavior, 98% of them in the past year, with an average of 64 events that they experienced. So you can see this isn't a one-off. It's not, you know, one time in my career I experienced disruptive behavior. It's more of a constant pattern or a repeating pattern that people are subjected to. I'm going to show a quick little video, just about a minute, of an example of how disruptive behavior can actually impact patient care in a way that's maybe outside how you normally think about it. It's not the scalpel throwing, but something else.
I worked for a very senior, eminent surgeon who had a ferocious reputation. He did not want to be challenged. He insisted on being telephoned about every prescription that his patients were given, even the ones that I felt confident to prescribe. And then he would constantly find fault with the prescription. I ended up administering medication to a patient without recording the prescription, and the patient came to harm as a result of that. because the other doctors looking after the patient didn't know the medication had been given. When we sat down when I sat down and talked with some of the other doctors, they had also administered medication without recording it appropriately because we were all afraid to go to the boss and say this is what we thought the patient should have. So as a result, the patient suffered side effects from the drugs that we had given. There was no record of what we had done. There were interactions between the drugs, and obviously I felt terrible about that. Thankfully, the patient recovered.
So again, you can see it can have impact in a lot of different ways when a physician or other clinician is creating this environment of fear. Disruptive behavior leads to things like fear, confusion, uncertainty. Also can lead to feelings of wanting revenge. You know, people's egos are hurt. It can cause feelings of grief. You know, sometimes people, their whole outlook on their career as a clinician is impacted. People start withdrawing, becoming more apathetic. Certainly burnout is a significant side effect of being exposed to disruptive behavior. Also can create unhealthy peer pressure where people start doing things that they wouldn't normally do because everyone's sort of doing that to avoid this disruptive behavior. Also can lead to people, you know, not knowing what really is expected. They can sort of lose the strategy of these are our standards, these are our protocols, this is our chain of command, this is our standard of care. Really unfortunate consequence of disruptive behavior that's probably one of the most profound, I think, is how many people leave to escape, right? So people retire early, they switch to another practice, they relocate to another state. People do what they can to get out of this negative environment. And as I mentioned earlier, it leads to medical errors in many situations. The problem is that disruptive behavior from one person then causes more disruptive behavior because as people are trying to deal with it, they feel they can't function in the appropriate way. And so they start taking shortcuts or doing things, hiding things, you know, talking about people, whatever it might be, just to try and survive and get through. I mentioned the patient consequences. I'm not going to go through every single thing on the slides, but you know, in general, looking at big surveys, what we see is that disruptive behavior in many cases is associated with negative patient consequences. In a lot of situations, that's related to communication breakdown, particularly when trainees are involved. In terms of consequences to the institution, we know that, again, disruptive behavior causes poor morale, it causes people to leave, it impacts communication, puts you at heightened risk for litigation. It leads to people having less self-esteem in their work and in their role. It decreases the image of the medical center. You know, word gets around, people notice, they pick up on these problems, and it starts to impact how the community and even the academic community might think about the environment. It causes an unhealthy work environment, can lead to poor quality of care, and then also can cause a lot of confusion about, you know, what am I supposed to do in this situation? What is my role? Who should I talk to? How should I proceed? So it's helpful to think of disruptive behavior as a culture of wellness issue. So this is the Stanford model of professional fulfillment, where the idea is that there are these three components that contribute to our professional fulfillment. The blue one is the one we most think of as wellness, so our self-care strategies, like what are we doing to take care of ourselves? The efficiency of practice component is how is the organization set up to make it easier or more difficult for us to do the work we're hired to do. But then it's that culture of wellness. What does it feel like when you come into work? You know, what are the values? What are the policies? What is the environment like? Is there cooperation, communication, collaboration, right? Or is it more conflict and competition? And so what we know is that disruptive behavior not only contributes to a negative culture, but it's also a product of a negative culture. So the more disruption there is, the worse the culture is. And the worse the culture is, the more disruption you might see. So what are some things then that cause us, that lead to disruptive behavior? Well, we know that sometimes a person is just a jerk, but oftentimes what we know is that there are underlying health conditions that are contributing. So it may be a substance use disorder or other psychiatric disorder, might be a personality disorder. Oftentimes people who had a difficult upbringing and may not have developed good anger management skills, good communication skills, good coping skills. They don't know how to handle the stress of the medical environment. They don't know how to communicate properly when they are having a difficult situation, and it comes out in these inappropriate ways. Physical illness, especially if someone is dealing with a neurocognitive disorder, what may look like disruptive behavior may actually be symptomatic of early onset dementia or something else where they're not able to keep up, and they're either not aware of the behavior or they're engaging in ways to try and cover for the mistakes that they're making. Or social skills. So, a lot of clinicians were so busy during their training that they haven't necessarily developed the level of interpersonal skill, the communication that they need in order to, again, be successful in some of these scenarios. And then burnout, as I said, or even suppression of other problems. If someone is dealing with the fact that, again, they're going through a divorce, or, they just had a major diagnosis, or they're having problems with their children, or, whatever it might be, and they're trying to hold it together, and this is just sort of how it's coming out. So when intervening with these individuals, when someone is displaying disruptive behavior, what we often see is that it's first addressed at the level of the institution. So whoever is the employer, if the person has an employer, will step in. It might be human resources, it might be employee relations, it might be the chief of staff or a hospital wellness committee. And so typically there's a disciplinary response, right? There might be reprimands. They might be put on probation. They might have a letter in their file. Sometimes they're put on an improvement plan or sent to the EAP for some counseling. Sometimes they're referred for professional coaching. And sometimes this is enough and it helps and is able to address the problem, particularly if the issue is that the person just doesn't have good insight into how their behavior is affecting others. Sometimes having it brought to their attention, getting some good counseling and coaching can be effective in sort of retraining them in some of those skills that maybe they were lacking. However, those interventions are often not sufficient if there is an underlying health condition that's really the root cause of the disruptive behavior. If there is a substance use disorder, if there is a psychiatric disorder that's untreated. And so that's where a physician health program might be really helpful in guiding the referring institution in figuring out what's going on and what level of intervention is really needed. So what's the appropriate evaluation that the individual needs? And then on the basis of that, what sort of treatment should they get in order to proceed forward and be safe to return to work? We did a small study about a decade ago, actually, at Florida's program, where we just looked at the chart review of 54 individuals who had been referred to our PHP due to disruptive behavior. And what we found is that only 2 of them had no DSM diagnosis. So a good chunk of them, 24%, had an Axis 1 diagnosis, another 22% had Axis 2, and then fully 50% of them had both. And so, this really goes to kind of demonstrate that oftentimes there are these underlying conditions at play. How do you refer to a PHP? Well, again, the first step is to call the PHP and just let them know what's going on. You can talk to them. You can talk to them even anonymously and say, here's a situation I'm dealing with, or, hypothetically speaking, if you knew that this was going on, would this be an appropriate referral to send your way? So I put here the phone numbers for the Maryland PHP. If you're tuning in from another state, you can look up your state program in the PHP directory at the Federation of State Physician Health Programs website. Almost all states currently have a program that you can refer to. Most of the programs will help with monitoring individuals who display disruptive behavior, particularly if there is an underlying health condition that is contributing. So once you've made an official referral, if they say that would be appropriate, please give us more information, then the PHP typically will contact the clinician and arrange for an intake interview. At that point, if the PHP thinks it's still an appropriate case for them to take on, then they will typically refer them for a comprehensive evaluation. In most cases, the individual is given a choice as to several different clinicians who might be appropriate to offer the evaluation, and then they can choose which one to go to. And then after the PHP receives the report back, then they determine, what is the necessary treatment and monitoring plan components based on the results of the assessment. So some common interventions in the instance of disruptive behavior is oftentimes the individual is sent to an assessment program that specializes in evaluating disruptive professionals. So sometimes this can be a briefer outpatient type of an evaluation, but sometimes, particularly if it seems like there's a lot going on, it may be a multi-day or even a week-long evaluation that includes a medical workup, a psychiatric evaluation, a substance use disorder assessment, neuropsychological testing, personality testing, collateral information, which may come from family, from colleagues, and the referral source, of course. And then the types of recommendations that might be offered include things like an intensive CME course for professional behavior, sometimes outpatient treatment, particularly psychotherapy. In certain cases, residential treatment might be recommended, particularly, again, if there's an underlying substance use disorder. Long-term psychotherapy may be indicated if there's a personality disorder or other, severe or significant psychiatric component. And then oftentimes they'll request 360-degree evaluations of the individual so that, they're getting feedback from their peer colleagues, but also their supervisors and also people that maybe they supervise or they teach. So those distress professional CME courses I alluded to, this is really designed specifically to meet the needs of professionals who have some problematic behavior in the workplace. So the idea here is that they're teaching them specific skills, communication skills, teaching them some insight and how their behavior is impacting others, teaching them about accountability, how to gauge how their behavior is being received by others. And what's nice is it occurs in a group setting. And so they kind of call each other out and are able to, notice things in one another that they can't necessarily see in themselves right away, but allows for them to build insight sort of externally first and then more internally. But learning about healthy boundaries, learning about how their childhood experiences might be impacting their current functioning, things like that. Typically, these courses are a weekend, like a 3-day weekend, and then maybe have additional follow-ups, a 1-day follow-up a month later, 3 months later, 6 months later. And there are a few different centers around the country that offer these courses. In terms of the PHP monitoring, that typically, again, they might be recommended to attend one of these distress professional courses, perhaps an anger management program, maybe professional coaching. Oftentimes they'll ask for reports from someone in the workplace who acts as a liaison or a worksite monitor to report back to the PHP. Treatment for any underlying psychiatric disorder, which might include psychotropic medication and or psychotherapy as indicated. Treatment for an underlying substance use disorder, right? So if the individual has a substance use disorder, they'll typically be referred for treatment and then maybe ongoing therapy, continuing care, as well as random toxicology testing, participation in mutual help groups like a 12-step program. And then many PHPs also offer facilitated monitoring group participation. So this is where the individual will have an opportunity to meet with other healthcare professionals in monitoring and check in and sort of keep track of how they're doing in their recovery, just to ensure that they're staying on track. Okay, so switching gears then, what is unprofessional sexual behavior? Well, the Federation of State Medical Boards Work Group on Physician Sexual Misconduct has this definition. They refer to professional sexual misconduct as behavior that exploits the physician-patient relationship in a sexual way. This behavior may be verbal or physical, can occur in person or virtually, and may include expressions of thoughts and feelings or gestures that are of a sexual nature or that a patient or surrogate may reasonably construe as sexual. So it's a much broader definition than just, having sex with your patient or, sexually assaulting a patient, something like that. The FSPHP put out a statement on sexual misconduct. That's the Federation of State Physician Health Programs in 2019. And I just want to highlight a few of the key components there. First of all, professional sexual misconduct with patients is always wrong. There is no situation where a PHP would condone it. It is always seen as the physician's responsibility. So even in a relationship that the physician and maybe the patient are initially describing as consensual, it's the physician's responsibility to set appropriate boundaries and to protect the patient. Sexual conduct involving a physician and a patient can never be considered consensual. There's always this inherent power differential. And if a person knows of sexual misconduct, it should always be reported to the state medical board. And that's if it is, the patient, or you have observed something, or you've heard about it, or, you receive a referral as a physician health program. Physician health programs, if they are referred these cases, contact their medical boards and work in conjunction with the medical board. They do not provide the same level of confidentiality as they might with a health condition. So how does professional sexual misconduct or unprofessional sexual behavior typically become known? So with the disruptive behavior, we described how it's usually complaints from patients or colleagues. In this situation, it's often that there's legal system involvement, whether it's a civil lawsuit or a criminal case. Sometimes there are complaints made to the clinician's professional organization or to the licensing board or the Department of Health. Sometimes there are grievances in the workplace. And also often what can occur is that if an individual is being monitored for some other conditions, sometimes the PHP will then become aware of unprofessional sexual behavior that also needs to be addressed. So when thinking about intervention then, Andrews and Bonta describe this sort of trivariate response, which is you first need to consider the level of risk in order to determine what type of treatment is indicated. And then what are the specific needs that this individual has? So, is there a co-occurring substance use disorder? Is there a significant trauma history? What are the things that need to be considered to put the person in the appropriate treatment setting? And then the treatment needs to be responsive. So it has to match the characteristics of that individual and be able to be flexible based on how they're progressing, those sorts of things. There are studies showed that if you adhere to those three principles, it significantly increases the treatment effect. So the goal then really is we want to put people in the right placement. We want the right services in the right amount. It needs to be the right intensity level. You need to connect them with the right structure and support, the right people. So, this is a very difficult issue to treat. You can't just go to your friendly neighborhood psychotherapist and say, hey, I need you to treat this doctor who's engaging in professional sexual misconduct. Absolutely not. There are specific individuals who really specialize in treating unprofessional sexual behavior, who specialize in working with professionals with these concerns. And it needs to be a referral to someone with that level of expertise in order to feel confident that they're going to be able to really provide some appropriate intervention. So the intervention needs to be at the right time and in the right place. So again, sometimes this means the individual has to step away from practice. So, I mean, typically if someone's engaging in professional sexual misconduct, there's going to be a withdrawal from practice, but it may mean that they have to step out of their community for a while. They need to go away for residential treatment. It might be a longer term stay. That brings us to the next one, though, is at the right price. So depending on the individual, can they afford this? You know, what options are available that fall within the feasibility, right? And this is an area where, just generally speaking, we need to do a better job of getting access to appropriate treatment, especially for our healthcare professionals. You know, many people think, oh, you know, they're doctors, they make all this money. But oftentimes when people are embroiled in a potentially impairing condition, you know, they're not functioning very well. They might not be doing financially so well. And these treatments can be very expensive. And it also requires being out of work for a time, which is also expensive. But that's what the steps we need to take in order to achieve the right outcomes. So when thinking about, can this person go back to work? You know, you hear sexual misconduct by a physician. Many people think that person should never practice medicine again. But again, the scope of behavior can vary widely. So it may be that the behavior is looking at pornography on a work computer. That's very different than, you know, molesting patients. And so there is some gray area. There is some room for really good assessment, really deep consideration of what is the risk, what is the potential for recovery, what do we need to do to ensure that before this person goes back to work, if that's even a possibility, that we are setting them up for success and we are creating a safe environment for them to return. So the types of questions we might ask are things like, you know, what is the disease state? What is the behavior? Is there a potential underlying condition that's causing some impairment? What is the nexus of the impairment and the behavior? Can we treat that, right? So is there something that is leading to this behavior for which we can provide an appropriate intervention that we would then expect the behavior to stop? Is complete recovery a reasonable expectation? What would that look like, right? And so if at the end of the evaluation, it appears that this is a person who would be appropriate for intervention and potential for returning to work, then that's when we might consider involving the PHP case management services. So then, you know, the questions become, what amount of leverage is necessary to ensure their compliance to the monitoring plan? What is the inclusion and exclusion criteria? Like, who are we allowing into the program and who are we saying, I'm sorry, we are not an appropriate resource for you. You are not someone that we feel we can monitor safely to return to work. You know, are we looking at risk reduction? Are we looking at complete recovery? Like, what is reasonable here? And what are the key components of monitoring that can help with that? And then again, looking at what are the clarifications that we need to make so that the stakeholders have appropriate expectations. You know, what is the return to work that we're looking at? Is it someone where they want to be approved to return to do like insurance review, right? So they're going to go back to some position where they need a medical license, but they're not actually engaged in patient care face to face. You know, those kinds of questions come into play. So again, it's the same process for referral to the PHP. I'm not going to belabor this because the same slide just repeated, but just to, you know, remind you that that can be step one, is if you hear about some situation, you can always reach out to your PHP and talk to them. They are the experts. They're the ones who know, you know, what's the best next step, what would be appropriate options for next steps, and they're here as a resource to help. So assuming someone is referred to the PHP and they're sent for an evaluation, you know, what are the ongoing questions that need to be addressed? Well, most importantly, you know, what sort of practice restrictions or modifications might be necessary if this person is allowed to go back to work. So do we need to restrict the gender of patients that they work with, the diagnosis of patients, the age of patients that they're allowed to work with? How about the setting? Do they need to be restricted to, you know, a group practice setting that solo practice is no longer allowable? Or maybe telehealth would be okay, but not in person. Maybe they need to be employed by someone else, right? What treatment modalities might be appropriate for them to offer? Like maybe psychotherapy is not something that they should be offering to patients anymore. Maybe if they're having issues with inappropriate prescribing, then we need to look at that as well and consider, should they be in a position where they are prescribing things? Maybe not. If they're not fit to practice, are there any currently, then are there steps that could be taken to address the area of concern that maybe in the future they would be fit to practice? If not, you know, is this a person who really needs a hiatus? Do they need to leave medicine temporarily or, you know, permanently? Or, you know, perhaps they could stay in medicine, but maybe retrain in a different specialty, a lower risk specialty. And then, you know, what steps need to be taken to reassess their fitness to return to practice? If they don't seem to be appropriate now, when should we reevaluate them? What might that look like? So assuming the person is referred then to treatment, you know, the types of questions that might be addressed are things like, does this person suffer from a psychiatric illness? If so, you know, what is it? Is it being managed? Can we manage it? Can we treat the psychiatric conditions sufficiently so that they can return to practice? During treatment, are we noticing, are there any new things that have come up that maybe we would change the recommendations, the initial recommendations, either more restrictions or maybe less restrictions? Does this person have a full and comprehensive understanding of professional boundaries? Is this something that now they get? You know, sometimes there are cultural issues that come into play, and some education, some training can be, some coaching can be very valuable. If we allow them to return to practice, will they be able to maintain those appropriate boundaries? Are there any treatment suggestions that could help them to maintain those professional boundaries? Like, are there new skills they need to learn? Are there parameters we can set up? And really, you know, again, continuously gauging across the course of treatment, is this person fit to return to practice or safe to return to practice? Or if they haven't, if they're already in practice, should they remain in practice? We recently in Florida did a study, it's currently in press at the Journal of the American Academy of Psychiatry and the Law, where we looked at our referrals for unprofessional sexual behavior over a 35-year span. So this started in the 1980s and kind of continued on from there. So we looked at the case records from all these individuals to see, you know, what was going on in these situations. And what we found was that out of the group that was referred, only 232 of them were actually monitored. And of those, a number of them had an underlying potentially impairing condition. So you can see on the slide there, a significant chunk of them had an addictive disorder, and many of them had a psychiatric disorder, particularly personality disorders. We started with 572 records that we reviewed. These were records that, you know, based on a keyword search, pulled their charts. We identified 2 of them where they were actually victims of professional sexual misconduct, not a perpetrator of unprofessional sexual behavior. So we eliminated those records, but that left us with 570. And what we found is that only 40% of them were deemed to be appropriate for monitoring. So in, you know, most cases, they were either turned over to the board, they relinquished their license, the board handled it without involving the PHP or before the PHP could get involved, or they were deemed inappropriate for some reason. You know, they were not someone who the evaluation indicated would likely to be able to return to practice. Maybe there was significant legal involvement. But again, there are a number of different cases that were not able to be served by the PHP. For the cases that were deemed appropriate for monitoring, you can see a variety of different types of monitoring agreements were signed. Some of them had a substance use disorder contract or a psychiatric disorder contract, disruptive behavior. Only 88 of the cases actually had a primary boundary violation monitoring agreement. And so that was, less than half of the ones that were referred that were actually approved for monitoring. So what does monitoring look like with this group? Well, typically, again, the individual will be referred for treatment for any underlying condition, whether it's a psychiatric or substance use disorder. They typically will be assigned that worksite liaison, someone to monitor them and report back to the PHP. Oftentimes, they'll be assigned a chaperone, so another person needs to be in the room with them when they're with a patient, so they're never alone with patients. They might have staff surveys back, asking the staff, how is this person doing? Have you noticed any problematic behavior? Also, oftentimes, it'll include patient satisfaction surveys, getting feedback from the patients about how the clinician is behaving in the clinical setting. Polygraph testing is frequently used to, gauge whether the person is adhering to the monitoring program requirements. And then those practice restrictions I mentioned. So, what type of patients you can see, what type of setting you can practice in, maybe whether you can work full-time, part-time, etc. And then I mentioned earlier, participating in those facilitated monitoring groups where you're meeting with other professionals in recovery from potentially impairing conditions, and or participation in mutual support groups, whether it's, a 12-step program like Alcoholics Anonymous, Narcotics Anonymous, if they have a substance use disorder also, or maybe Sex and Love Addicts Anonymous or something like that, if that's appropriate for them. Looking at the outcomes for the cases that we, reviewed the charts, what we found was actually very good results. So about 67% of the individuals at the time of the study had either successfully completed monitoring or were still under the monitoring agreement. And looking at them, more globally, just kind of deciding, was this a successful or an unsuccessful attempt at monitoring? 74% of them were viewed to be successful or very successful, meaning that they completed their monitoring and graduated, or were currently in monitoring because their period of monitoring hadn't ended and they were in good standing. The differentiation between successful and very successful was that the very successful, there was no blips during the monitoring. There were no issues that came up. Whereas for some of them deemed successful, maybe the monitoring was extended due to some, some reason why they felt it would be helpful to continue it. There were some very unsuccessful and unsuccessful cases, people who were turned over to the board, people who, had a reoffense, things like that, but it was a very small proportion. There's another study, I know I'm running out of time, that was published by Colorado's PHP, where they looked at 19 years of monitoring for physicians who had a boundary violation. Some of those were sexual boundary violations, and some of them were non-sexual boundary violations. So, going into business with a patient, something like that, where it just is inappropriate, but not in a sexual way. And what they found is that clinicians who had a non-sexual boundary violation in the past were more likely to then have a sexual boundary violation later. And so that is really a risk factor to be watching for. But for those who engaged in monitoring, 88% of them had a successful outcome and had no further incidents of boundary violation across all the categories. And that was a monitoring average of 950 days, but up to about 4 years of monitoring. So final thoughts, as I tried to make clear at the beginning, unprofessional behavior really has a negative impact on everyone, on the patients, on your colleagues, on the families, and on the clinicians themselves. For people working in this space, knowing the laws and the confidentiality limits for unprofessional behavior within your state is crucial, particularly if you are working with someone who's predatory or engaged in professional sexual misconduct or other offending behaviors. It cannot be kept confidential, and they need to be referred to a clear specialist for treatment, for assessment and for treatment. And intervening with these individuals is really challenging. So it's important to educate your team, support your team. It can be difficult for them to work with these people because many of us have, a negative reaction hearing these stories. And so having the empathy can be a challenge. So I will stop there. I want to say thank you for your attention, and also just acknowledge a few of my colleagues who have presented on this topic with them in the past. So some of the slides I presented today are slides that we've presented together and or they've shared with me. So I'll stop there for questions. I know I only have a couple minutes, but I can stay for a few extra minutes if there are more.
I have a question.
Go ahead, Pam.
All right. When you were mentioning these groups of physicians, did those include fellows and residents?
Which time are you referring to?
The last three present studies that you presented on. You said
Yeah.
physicians.
So our Florida study definitely includes residents and fellows as well as practicing physicians. The Colorado study, I don't remember, but I believe that they also include residents and fellows in their data set.
Okay, we have a question in the chat. Can you talk a little about the clinical issues associated with mandating disruptive professionals into coaching or psychotherapy?
Oh, that's a toughie. So, the issue with people who have disruptive behavior is oftentimes they are not the ones who are most receptive to suggestions about how to improve their behavior. So there can be a little bit of a tightrope. If you are someone who is trained in motivational interviewing, that can be very useful. Oftentimes what tends to happen is that, it starts off with, the chat over coffee, where a colleague will come and speak to them about their behavior and concerns. If that doesn't work, then it gets escalated, and typically that's where the institution would become involved. So the human resources or employee relations. What can happen sometimes is if the person really doesn't want to participate in the requirements to continue their employment, then they'll leave and go somewhere else. And unfortunately, again, this issue of unreporting follows. So, they might then look for a job at another institution or organization, and someone calls to do, a reference check, and no one mentions the disruptive behavior. Sometimes it's like, good riddance. I don't want to risk that person now suing me or something else. And so it does tend to prolong and perpetuate the problem sometimes. I think the best scenarios are when the individual is approached not from a punitive way, not from an accusatory way, but to say, hey, we want you to be successful here. What we're observing with these behaviors is these behaviors are not allowing that to happen. And so we need to take some steps to address the behaviors. Here are some things that we think would be helpful, and try and get their buy-in, just like you would with, any other condition. But again, it does take some clinical skill to make the case and to get them on board, and sometimes takes more than one attempt. But, for patient safety and for the health of the environment in which you're working, it is really important to address these situations.
Absolutely. Other questions? I don't see anything else in the chat, but does anybody have any additional questions? Well, I definitely want to thank you, Dr. Merlo. This was very, very informative.
Margaret, I do have one question.
Oh, sure.
Sorry, Dr. Merlo, this has been fantastic. This is Alan Browder. I'm the executive director of the center. I guess my one question would be, and I've challenged my team to answer this question, is what is success? I've seen all of your, everything that you've presented has been incredible, and we'll be able to take this for our team, and I hope everybody that's on this Zoom will be able to take it for theirs. But when you determine success, I guess the ultimate impact is ensuring that we get physicians the help they need. If we don't, or if that means that a physician doesn't present or a physician doesn't practice anymore based on what we've determined, I view that as success, because we came in and did what we needed to do. We were the intermediary. So when you have your stats and data around success, what should we be looking for as a PHP program when physicians come in, to be able to be able to say what success looks like to us?
That's a great question. You know, there's so many stakeholders involved, right? So it's who's success, who is determining what's successful. I think from the PHP side, you have to keep in mind that dual mission of protecting the public, right, from clinicians who might be practicing impaired, and also helping to advocate for the professionals. And so I think on the PHP side, again, it's so important to come at this situation with the goal of, we want to help you to be successful. We are getting reports from your workspace that you are not being successful currently. We want to provide you with resources, with opportunities, with guidance, with a plan that you can actually feel good about the work that you're doing, that your employer feels good about the work you're doing, that your patients are being treated appropriately. And, you know, sometimes what happens is they say no thanks and they leave, and sometimes they end up coming back later, and it might be, you know, a second, third try before you can actually get there to what we would think of as really success. But I think that that's not dissimilar from a lot of the other potentially impairing conditions that we work with. So, you know, you might have the same situation with someone who has a substance use disorder who, upon initial referral, says, no thanks, I don't like what you're selling, I'm going to go do this on my own, and, you know, take their chances with the licensing board or whatever it may be. And again, oftentimes you'll see them back in your office again later down the road when there's a new level of insight or new contingencies, you know, new pressures on them to actually engage and kind of listen more closely to what it is that you're offering, and give it a try. You know, from the workplace side, like, one bad apple really does spoil the bunch. You know, that small number of people exhibiting disruptive behavior affects everyone. So it may be that the employer has to say, you know, you're an excellent clinician, you're a valued member of the team, but like, we can't keep you here. The negative impact on the rest of the team and on the patients is just too great. And sometimes it takes that drastic situation before the individual really is able to kind of see the extent of their extent of the impact of their behavior.
Yeah.
So.
Thank you.
Thank you. Any other questions?
It looks like there's no one in the chat. Can you speak to any experience or recommendations you have with physicians who viewed pornography at work? This has recently come up in our program. Yeah, so I am not a qualified, you know, sexual therapist. So my recommendation would be that you need to connect that person with someone who really is a specialist in treating these individuals. There is, I'm blanking on the organization, the Society for Professionals.
CSAT? Yes, I believe it's CSAT, Society. Yes. I can't remember what it stands for, but CSAT, yeah.
Yeah, so, you know, finding someone in your area, or even someone who could do a virtual evaluation, sometimes that's an option, or someone who they can go for an in-person evaluation that might require some travel. But you really need to work with someone who has expertise in this area in order to help them identify what is going to be successful in, you know, if it's a compulsive sexual disorder, you know, sex addiction, something like that, then there are good treatments available, but you really have to have them working with someone who specializes in that and knows what to do.
And Lisa, I'd like to add to that the VA system is very strict on that,
Yes.
and they monitor that on a regular basis.
Yeah, there are a lot of organizations now where you can get yourself into some big trouble.
And I think I've one more question, and it might be a follow-up phone call, you know, maybe in a week or two, but you started your lecture off with information about just what it is that a PHP program does. And I think you know, it's so similar to any workplace, you know, the medical field, you know, doctors in general, what you're saying in terms of conduct, they resonate towards everything. It's not just medicine, it's professional behavior in general. So if there's a negative in anything, bad apple, person that doesn't necessarily take orders or take rules in a certain way, that can have a negative effect on everybody. In a lot of different workplaces, there are already rules in place and steps in place to mitigate those things, or you know, whether it's firing, whether it's whatever. In the medical field, I do know it's different, and there's no protocol necessarily. That's why we have a PHP program, thankfully. But what would you recommend? Is there something that should be recommended to all hospitals? Is there something that should be recommended to all medical centers, all physicians, that says like a code of this is what, like, should there be something created, or I don't know what it is, but I feel like if we're dealing with patients' lives and we're dealing with the health of all citizens, should there be something that's at least created that says if you do this, then this happens? Yeah.
I think it would be wonderful and super helpful if something like that could be created. I think that it's unlikely to happen. The situations can be very dissimilar, and I think this is a little bit cynical of me, but I think the reality is that what is allowed to occur may vary depending on who the perpetrator is. So if you are, a CNA and you engage in a behavior, you might be fired immediately. But if you are the neurosurgeon who is bringing in millions of dollars to the hospital every year, there tends to be a lot more leeway. And so what I would love to see is a more consistency in how the same behavior is addressed, regardless of how much money the perpetrator brings to the organization, because unfortunately a lot of this gets swept under the rug, and some organizations feel that, we can afford to lose some low-level staff who can't stand working with this person. It's kind of collateral damage that they're willing to write off in favor of allowing this person to continue inappropriate behavior because of how much money they bring in. So I don't want to end on that negative note, but I think that that's where a big part of the sticking point comes in a lot of the time.
Yeah. Great, thank you. And it's not a negative note. You've been fantastic. I think I learned a ton, and Margaret can stop on this. Or there could be more questions, but I thank you for answering those, and I will have more follow-up questions, and I'll put those in an email.
Well, thanks very much. Great questions, Alan, and great discussion. Again, thank you so much. This was so needed, I think, and so well presented. Don't be surprised if we ask you back, okay? Just want you to know that. For anybody attending, I also want to let you know that tomorrow you will get a link for the questionnaire for the CMEs. If you have any questions about it, obviously you know how to get in touch with me, again, Margaret Crone. Please know that you will get that tomorrow. If for any reason you don't get it, by all means, let me know. Thank you so much for spending this time this evening with us. So appreciate all of the support and partnership that all of you have given to MPHP, and then also to the PHPs that you all are associated, that some of you are associated with, because I see you from, you know, a number of different places. So thank you. Have a great rest of your evening and a great rest of your week. And stay tuned for our symposium in October. See you all then. Thank you.